Right, we'll make a start. I've seen that all our speakers are here now, which is a good thing. So just to introduce myself, I'm Duncan Cooper. I'm the Associate Director of the Reducing Inequalities Alliance, and I'll be your chair for today. And just to check everybody's in the right place, this is the second of 5 events during our Reducing Inequalities Learning Week. The title of today's session is Seeing the Whole Picture, Working Towards Holistic Care. So we've got 2 presentations that we'll move to in a little while. But just to start off with, just a little bit of housekeeping. Could you please put yourself on mute while you're not speaking? That would be really helpful. Somebody just heard them, so that's ideal timing. So put yourself on mute. We're going to be recording the session today. So if you don't want your camera on and you don't want to be seen on the recording, please make sure that you turn that off. And people might be taking screenshots and tweeting things as well. So turn your camera off if you don't want to be seen. What we'll do is we'll go through the 2 presentations and then ask all the questions at the end. So I just want to make sure that both speakers get a chance to talk about their projects. So we'll do that at the end. And then we've got, if you're into Twitter X, our hashtag for today is Reducing Inequalities BDC, all one word, hashtag Reducing Inequalities BDC. So if you just put that into Twitter X, you'll see a few tweets on that. So that's the background. One of the things as well is that we're aware that people are coming to different sessions throughout the week. So just to give you a little bit of background on reducing inequalities in communities, if you don't know, I'll just give you a couple of little sound bites on that. So the Reducing Inequalities in Communities programme was set up in 2019 in City CCG, which is a sort of central part of Bradford. That was because of the significant inequalities that bit of Bradford faced. There's a 20-year difference in healthy life expectancy across Bradford District and Craven. That gap is still there, unfortunately. So it just shows how difficult inequalities are to remove. But that's why we started in that bit of the city. The programme, excuse me, has overseen 21 different programmes during those 5 years, and we're going to showcase 2 of them today, taking a life course approach. So we've got programmes that are going from children and children's wellbeing, mental health, right up to frailty and dementia. 16,000 people have benefited from the RIC programmes over the last 5 years, and that includes hundreds of volunteers, and we've also got 100 new staff that were brought into the RIC programmes. So what we're doing over the next week, this is the second of 5 events, is just to showcase some of the general lessons and some of the learning that's coming through from RIC. So that's a bit of background on RIC, and Sophie will be putting in various URLs and bits and pieces in the chat as well. So you can have a look at signing up for the other events, you can have a look at the RIC website, and you can have a look at all the stories and learning that's come out. So have a look at that, keep your eye on the chat. Put your questions in the chat as well, and we'll make sure that we try and come back to all of them at the end. If we don't, we'll make sure that we get in touch with Dean. We'll hunt the speakers down and make sure that we can try and get some answers back as well. Okay, so I think that's it really. What we've got today is we wanted to have a focus on holistic care. So we've got 1 project from the mental health world and 1 project from long-term conditions and frailty world, and bring dementia as well. And the theme of the session is really about how we can adapt our services to recognising that person as a whole and the impact on patient outcomes with a real holistic view. So we've got Amanda Whitley and Rachel Bannister, who are going to join us to talk about one of those programmes, which is the proactive care team work. And then we've got Sasha Batt from Healthy Mind, who's going to talk about culturally adapted behavioural activation therapy, or CABAT, which is a good short for that. That's 2 really good examples of that work. If I've got any of that wrong, please tell me off. I can see a screen. I think we're going to go, Amanda, we're going to go to you first. I can see 2 people on your screen. I believe that Sophie's going to share the slides for you. So we'll hand it over to you. And I think you've got about sort of 15 minutes or something like that to talk through, just to make sure that we've got some time for questions as well. So over to you.
Thank you, Duncan. Just to say, it's Amanda and Sue Butters that's going to be presenting.
Okay, all
and
right.
Rachel's going to jump in with Sasha in the second presentation. So I'll just share my screen and over to you, Amanda and Sue.
So I'm Sue Butters. I'm anticipatory care lead for the Care Trust.
And I'm Amanda Whitley, I'm the Proactive Care Team Leader.
And we're here to talk about the Proactive Care Team. So first slide is about partnership working. So we're an effective example of collaborative working. So the team are made up of staff from the teaching hospitals who provide our therapists with impact, the District Care Foundation for our pharmacists, nurses, and our mental health aspect of the team. We've got social prescribers from other RIC projects, so we work with clicks. Admiral nurses sit within our proactive care team. We link every day with the voluntary sector. And more recently, the local authority we have an MDT with one of the social workers, so we're linking now in with our local authority colleagues. Our MDTs are 4 times a week, and they are inclusive of anyone involved in the patient's care. So we include those professionals that work with our patients and that know our patients the best. Next slide, please, Sophie. So within proactive care, we've got 11 disciplines, and we work in a unique way. It's a coordinated way, in a holistic way, and we prioritise highest needs as a collective of professionals. All our professionals have got a breadth of experience now of working in Bradford City, and include allied health professionals, nurses, we've got a GP, pharmacy technician, and we have a really good balance of physical health and mental health. And we look at the interactions between mental health and social and physical health and address the needs in looking at the priority of those needs. Next slide, please, Sophie. So our approach. So we provide holistic short-term care for over 18s, and we work with carers and families. Immediate and short-term needs, it's a wraparound service to avoid unnecessary GP appointments, unplanned hospital admissions, and signposting to the right services that are out there. Interventions offered are integrated, including our MDT. We work alongside local GPs, other primary care services. We have access to A&E attendances, physios, mental health support, wider groups of people, and in terms of those mainstream services that we signpost on to when we've seen them from a proactive care perspective.
So what we do, we work proactively to identify patients who perhaps have got an unmet need. It's the frequent service users, or often patients through our case finding tool, the radar risk stratification. We often find patients who have not been known to any services, and we've found that some of these patients that we've often had the best outcome, they've just slipped under everybody's radar, and then we offer this wraparound service for a holistic assessment, and we can pick up on quite a lot of unmet need there. We have an inclusive rather than an exclusive criteria. So very early on, we removed most of our exclusion criteria, and basically if you're over 18 and you need more than one discipline within the MDT, then we will review your case and offer you an initial assessment. From the MDTs, we offer a coordinated plan of care that has short-term, medium and long-term interventions, and at the end of our care input, we make sure that you've been referred on or have a wraparound service, know who to refer to should your condition escalate in the future. Next slide, please. So establishing the service, we recruited in collaboration with our partners. So it was BDCT and BRI and primary care who all supported with the recruitment. And the initial disciplines have evolved and changed as we've gone on and learnt from our patient interactions what the needs of the service have been. We've now taken on mental health nurses, which we didn't have originally, pharmacy technicians and things like that. We've created, although we use System 1, we had no system in place to support the team originally. So we've built in templates and a systems approach that in order for us to be able to input and share, build in referrals and all the robust things that a service needs. Using our business intelligence, we make sure that we are collating information that supports our evaluation and that we're meeting our key performance indicators with the commissioning. We do engagement both internally within BDCT and externally to very many different organisations and factors. And when we originally set up, we were in COVID, so it was really difficult to establish a service when everybody was in lockdown and we couldn't do lots of face-to-face things and just pool up to meetings and things. So we had to do a lot of that via Teams, the new thing that we're all used to now. And so, yeah, we worked really hard about establishing and engaging with all our partners. We have an ongoing review and reflection approach. So we trial things out. We regularly have meetings to review, is everything working? Do we need to change anything? Do we need to develop anything further in order to support the service and the patients that we're seeing? And we do originally the disciplines were 11 disciplines all together, and we worked as separate disciplines and everybody did their little input, and we worked really hard to make it more of a collaborative team approach. I'd challenge, other than uniforms, if people came in, you probably wouldn't be able to target who's a nurse, who's an OT, who's a physio. We have shared competencies, we do shared training, we've blurred all them boundaries between all the different disciplines so that we can provide much more of a holistic assessment, so that when a packed team member goes to visit you at home, they can do that initial information gathering and triage for all the different disciplines, and only when it get to that elevated level do you need perhaps the discipline specific skills. And you still do have your discipline specific skills. Everybody knows what their role is and how that fits in uniquely with impact, but we also have this blurred boundary that makes us a collaborative team. We have regular safety huddles so that we're addressing all the things such as news scores, which we've adopted to try and identify deterioration and a deteriorating patient and early escalation of people who are acutely unwell. And we're very conscious of making culturally specific outcome measures. We use a variety of outcome measures to try and measure what the team are providing in an EQ 5D, which is a sort of, it gives us a number from a patient reported outcome, and then we use the TOMS, which is a therapy outcome measure, but the whole team use the outcome measure in order to demonstrate our improvements that we're making with the patients. Next slide, please. One of the areas that we focused on initially was around palliative care in the city centre of Bradford. There were the gold standard framework meetings and things weren't happening quite as much as perhaps we'd have hoped. I think there was 4 when we initially started 3 years ago, and recently last month we've now 100% of practices within the city area are having gold standard framework meetings. So building in those better conversations to be able to provide that palliative care support across the full community has been really one of our successes. We try and do early identification of patients in the last year of life, and we're supporting patients and their families to be able to have conversations that was previously avoided, and it was not often talked about. So we're working really hard to make it a normal conversation to be able to be planning those last years of life. And we're making sure that we're using the EPACS data and the system so that we've got that shared information and shared approach to end of life and palliative care planning. We proactively case find patients. So when we sat there on day one, we waited for this influx of referrals to turn up, and none of them did. And we were like, oh, what's going on? And so what we did is we started proactively seeking patients, and we do proactively find most of our patients rather than have referrals. And we do that in lots of different ways. We do engagement in communities and community centres, so patients are able to find out about the service and self-refer. We also target A&E and various wards. We link in with our community colleagues within district nursing, the community matron service, and the allied health professionals in order to find patients. And we also use the risk stratification tool, which we've used various connotations of reports. So we've tried everything from 2 A&E attendance to an A&E attendance and a fall, or a frailty score, or an age. We've used lots of different connotations of running the report through various of our GP colleagues who are really supportive in this, so that we can do that element of case finding. And basically, we give you a ring at home and have a conversation with you about doing a mini holistic assessment on the phone to see if you have any identifiable problems that perhaps proactive care can support with. And then we arrange a visit to come and do a face-to-face holistic assessment. Next slide, please. I think it's skipped one, isn't it? Yeah, Admiral. So we also have Admiral Nursing, which is a we have 4 Admiral nurses within our team, and we link in with Dementia UK. It's a partnership working, and it's around earlier diagnosis, and the Admiral nurses within the team support the carers of the patient. And the reason why it works so well with the proactive care team is that the proactive care team will often adopt the patient who has the dementia, and the Admiral team will support the carer. So we can do that holistic assessment, we can optimise their care, we can make sure that any sort of health issues that are going on or underlying that might be impacting their behaviour and things like that are addressed and resolved. And therefore, the Admiral team will put in safer practices for the carers and support, so that the patients and the carers know who to contact should they have any problems in the future. And we link in with the mainstream mental health services, the CMHT, in order to support getting that earlier diagnosis. Our occupational therapists and things will often do some preliminary assessments that will support the information that by the time they've got to the memory service. So we work very closely with the Admiral service and the Dementia UK. Next slide. This sort of speaks for itself. We've had, I think it was the back end of 2023, when we'd had 3,102 referrals up to date. 61% of the patients who were seen as being identified in the last year of life had a respect form completed, and our nurses are now fully trained up in being able to complete those respect forms, and they link in very closely with the GPs in order to achieve that. And 93.3% of our patients were seen within 2 weeks. And the ones where we've gone outside of that is usually at patient request, because they haven't wanted us at that time. Next slide, please. Yeah, family and friends, that sort of speaks for itself. 70%, 75% were very good, and 24% were good. So we get good rates of family and friends feedback. Next slide, please. Satisfaction. We do have a highly motivated, satisfied workforce within the proactive care team, and that has been demonstrated throughout the BDCT staff surveys, and we run a survey within the team also, and 84% of the staff said that they felt motivated and they felt that they had autonomy within their role, and 92% felt that they had the skills in order to be effective within their role. And I think this is what makes the workplace. Also, we have you're working with one patient one-on-one when you were there, and that we have no time factors. So we don't say we see you for 6 weeks and you're then discharged, or you can only have 3 visits and then you moved on. We don't put time restraints around the care that we're providing, and I think this really impacts the motivation and the staff satisfaction. Next slide, please. This is, yeah, that was just a couple of quotes from about staff, how staff do feel satisfied. Our mental health practitioner said it's about being in the office and having the next discipline next to you. So instead of having to chase around on phone calls and things, you can go up to the physio and go, I've seen this today. Does this mean this? Do you need to be involved? And everybody's in the office and you can speak to all them disciplines within a moment. And the palliative care nurse had pointed out that she'd been to see a patient who'd said, you know, please don't ever leave, that she'd felt so supported within that therapeutic relationship that she didn't want that episode of care to end within the pact. Thank you. EQ5D on here, which is the it's the patient reported outcome. So we do that at the beginning when we first see you, and we do it at the end at the point of discharge. The green elements are the bits where we've seen an improvement, and although you might think there's an awful lot of yellow in there, well, that's where people have maintained. Often for patients who are in the proactive care caseload, maintenance is a win, really, because you've not had further deterioration. And where you have had some where elements have worsened, it's obvious patients are palliative and they're going to deteriorate and they've got long-term conditions, so we'd expect that deterioration. I suppose what that doesn't capture is that they've got better support mechanisms around them. Next slide, please.
So when Rick started PACT, we commissioned a Bradford Institute of Research evaluation, of which we got the results last year. So after 3 years of service, the report came out last year, specifically measuring objectives around unplanned hospital admissions, accident and emergency attendances, and the difference on ethnic groups, improving health-related quality of life, and a cost consequence. It was a robust evaluation. We're really glad we collected our business intelligence and our outcome measures, and we got a control group that was similar to our PACT caseload, a group of equal levels of deprivation in Bradford. The results of the robust evaluation showed that patients that had been under the care of PACT had a reduced odds of A&E admission by 41%. And as the confidence intervals in this analysis were less than 1.0, we can be certain that the intervention does significantly reduce A&E admissions. The odds of unplanned hospital admissions was 31% lower in PACT service compared with the matched control group. So they were really promising. Pardon?
You haven't told her to say.
Next slide, please. And the next slide, Sophie, please. Okay, so future considerations. So it's a blueprint we've created in PACT. It's coordinated, it's holistic, it's patient-centred, and it's coordinated within multiple disciplines that can meet patients' needs. We use case finding to proactively seek out patients before the deterioration, before the waits for other mainstream services. We include everybody in our MDT. We've been allowed flexibility in developing a service, so it's been grown from clinicians up. We've had lots of support from Rick throughout this. We've had the steering groups, we've fed back, we've worked on PACT jointly. We've identified new roles to meet population health needs. So we've created roles where healthcare assistants have nursing tasks. They also have therapy tasks to do, and we delegate within the service. We changed one of the roles in the service to be a pharmacy technician because of polypharmacy within our patient cohort. We brought in mental health practitioners because we've got a high level of depression and anxiety within our patient cohort. So we've challenged traditional roles and ways of working, always considering adding healthy life to years within our population. We've had a physical presence within our communities, which has really helped with our the trust and building our relationships, our therapeutic relationship with our patients. And we've always worked to improve health literacy, so patients know where to go to seek help, and that it's not always A&E. So we're linking with our pharmacists and we're linking with our DTs. And that's proactive care. And we've got a short video, but I don't know if we've got time now, Sophie, have we?
I might just show a couple of minutes on it. I won't show the whole thing. I'm just going to have to reshare my screen so the sound plays. You just bear with me. Just want to make sure Sasha and Rachel have enough time, and then there's time for questions. So we'll just quickly play. If it's really bad quality in our event this morning, it wasn't the best. If you just put in the chat, and I might just pause it and I'll send you the link instead.
And she helped me, and she got the place for me.
Before PACT, I was self-isolated, more self-preserved. I wasn't going out. I was missing out on family gatherings, weddings. But now my confidence has improved. I've been more independent. I've gone abroad. I'm starting to go out with my friends and spend more time with my family. The PACT team has helped me. They've listened to me. They've heard me. They haven't judged me on anything, any problems. They've notified the GP. They've taken action upon it.
Well, I always found that they were more interested in my welfare than any of the other organisations I've seen.
With the GP, they have a long wait time. They don't always see you properly. The appointment's rushed. With PACT, they have a more tailored approach. They're more involved. They have more people on the team who are readily available to help. Any questions you have, they can answer on the spot. PACT helped me a lot because before I didn't have my routine structured, and now my life has completely been changed. I can wake up on time and I get to do the things that I should be able to do.
They were giving me moral support as well as their professional support. Whenever they came, I think, I must admit, they must have spent at least more than half an hour, sometimes maybe more. That gives you some hope, you know.
They used to come to see how I was without having to be requested.
कैथरीन अंदर में अच्छी फील कर रहे दूसरे जो आते हैं दूसरे जो आ रहे हैं उनका भी बहुत अच्छी बहुत केयर करते हैं.
So before I joined therapy with Rebecca, I was in a place where I needed to improve my mental health, and it wasn't where it needed to be. After going through a few sessions with Rebecca, we worked on my communication skills, worked on how to manage stress, worked on ways to tackle the feelings that I needed to talk about.
They're the best I've ever had as nurses. They let you do it at your own pace. They don't push you to do it if you're not confident enough. They help you with your mobility and make you feel more relaxed.
I have a rest because of them. They help me, and I'm so happy to have this team.
Especially Sister Kathleen and Wendy. If I need them through their normal telephone, connect, I rang them and they make an arrangement. Nobody can beat Sister Catherine, No. Are you feeling happy they are performing their duty or not?
Happy feeling. I like Catherine.
It's been a vast improvement. I mean, I couldn't stand to begin with. They helped me stand. I couldn't put any weight on my left leg to begin with. Now I can.
Jackie's helped me with my weight gain, my gastro problems have improved. Even the home visits, they're very convenient for me. Helped me with my sleep pattern and my social interactions. The people that I've met have been really kind, lovable, they're like a family to me. They've really helped me a lot build up my mental health.
All the team, whenever they came, they were all very, very well behaved and spoke nicely, calmly.
I used to go to the gym a lot and I couldn't do that anymore because of my weight, so they helped me get to the weight I needed, and then I was able to attend the gym, which I loved doing before. Overall, it's just been a tremendous help. And I just want to say a big thank you to all the team and everyone who supported me. Thank you for that.
I'm really proud of myself. I feel fantastic.
Thanks very much for that. That was amazing, actually, and really good to see like actual impact on real lives. That's what 40% reduction in aid admissions actually looks like. So I want to leave enough time for the final. We'll have a couple of questions now and hopefully come to a few at the end. I've made a note of them all, but just so we can, there was a few questions from, I just wondered, Sue and Amanda, there was one from Mohammed around the involvement of the faith sector and how spiritual needs and how the faith sector was involved in the work.
Yeah, we have reached out to services that sort of community centres and things like that, and we've reached into communities to be able to understand and link in with the faith sector. We initially had some training at the beginning, didn't we, from one of the imams, culturally competent training that we had in the beginning. And we also speak to our colleagues within the team as well, in order to understand different cultures and things that we come across. So yeah, we do reach out wherever we can. It is my desire to get into to reach into the mosques. I want to be stood at the door on when people are attending mosque in order to reach out that way. It's my to-do list.
Okay, thanks. And just one more question related to that came into the chat. Given that you've got 11 different professions working together, there was a question around whether those care plans are really carried out and used across all those different professions. And I just wondered if you could comment on that.
So there lies a tale. Are we goal setting or are we care planning? And in the beginning, when we couldn't decide one way or the other, whether we were a therapist or a nurse and what language we used, and then when we actually spoke about what the outcomes of that were, we realised it was the same thing. So we all work to one care plan, one goal setting. We have one template. We have a dashboard where each individual discipline can fill in their own discipline specific information, but then that is coordinated into a joint care plan that we all work towards. And that's what we discuss in our MDT, that we're working towards this joint care plan and that our actions are undertaken to achieve outcomes from that.
And I think that's where the coordinated approach is really important, because sometimes it's got physio written all over it, but if somebody's low in weight and low in motivation, no amount of physio is going to change that. So we have to work out who needs to go first to meet that goal. But the goal needs to be patient. They need to sign up to that goal for it to be successful. So it might be dietitian needs to go in first. We need to look at mental health, but it needs to be, that's the holistic part of it. It needs to be coordinated and negotiated with the patient.
Often our outcome, what we're working towards is being able to walk to the shop again. So it might not be a specific goal or care plan written by one of us. We work from what the patient wants, and we build in our therapeutic input around the patient identifiable goal.
Okay, thanks very much. I've made a note of the other questions. We'll try and come back to them at the end. So Sue and Carlton, etc. We'll hopefully have time for that. But I just want to move on now. So we've got time for Sasha and Rachel's presentation. Sasha, I believe you're sharing your own slides, so over to you.
Is that sharing? Just let me know if that isn't.
Yeah.
That's into a slideshow. Fab. So hello everyone and good afternoon. My name's Sasha Batt. I'm the Priority Director for Healthy Minds, which is our Bradford District and Craven Health and Care Partnership approach for mental health, learning disabilities, neurodiversity and substance use. And I'm going to talk about our Reducing Inequalities programme today, which was focused on culturally adapted behaviour activation therapy for depression for people from Muslim communities, or as we sometimes call it, CABAT, or more recently as CAT, which is just culturally adapted therapies. So why did we want to do this? A range of reasons, but primarily was our place-based feedback. People's experiences, a report that City Clinical Commissioning Group at the time undertook in 2017 really demonstrated the low access of people from the city area accessing talking therapies. So a really low uptake, a really high dropout, but re-referrals as that's what people were looking for to access in terms of their support for their mental well-being. And so we those were aspects that we really understood and knew that was a baseline. We also know that from a range of studies that providing culturally appropriate treatment is really recommended by the World Health Organization, by our NICE guidance, by Department of Health, and a real large body of evidence that we've helped contribute to from Bradford and from various services that that actually, how can we build that evidence that we can reduce the levels of depression and improve well-being by using faith-sensitive therapies. There's also a lot of research that's been taken place around people from Muslim backgrounds and the role that Islam, the role that their religion plays in their identity, and what that means in terms of their religious coping mechanisms, whether that's for mental health or other health ailments, and comparisons of that to other faith groups. And that gave us a bit of understanding of how we wanted to approach the issues that were highlighted in that report from 2017. And then a piece of work that Ghazal Amir, who was one of the lead professors from University of Leeds who worked with us on this, had carried out in Bradford, had shown that through some clinical trials that actually adapting some of the behavioural activation really helped support people to achieve their outcomes. And this was about people achieving outcomes, about their own goal setting and what was feasible for them within that framework of talking therapies. So, as I said, this was very much about putting faith at the centre of people's identity and how they interact with the world, and the role that religion plays in that, particularly when it's from an Islamic framework, and that people often, people do frame their world through that lens, which might be different to other faiths and might be different to other non-faith and spiritual approaches. So this was very much looking at that values assessment of how religion almost is a lens through which you might even view all the other domains of health assessment that takes place. And so it was very looking at what's important to the person, what gives their life meaning, what elements bring to light around their values, and how, more crucially, how do we activate those elements of that to improve their well-being and improve their health. And so it was very much about that element of understanding that those Islamic values and how they play core. And some of the key themes or quotes that we'd heard from people is, it's a core part of my identity. It's more than everything. Without their faith, they wouldn't be here. How important it was for them. The role of prayer in their life, and that while religion is a personal thing, sometimes it's the only way that they can talk about their personal health and their personal being. So very much is, the approach and the underlying ethos behind behavioural activation is in one of the stories that we have about the Prophet Muhammad, and it's a story where he was travelling through the deserts, and he'd met with a Bedouin who was about to leave his camel because he'd asked them to go for dinner, and the Bedouin was going to leave his camel without tying, and so the Prophet asked, well, why don't you tie your camel? And the Bedouin responded and said, well, I'm putting all my trust in God. And the Prophet himself said, well, tie your camel first and then you put your trust in God. And that's, that is a story, but it's how what the adaptive therapy does. It goes through different types of coping mechanisms, different types of language and values that you might use in a behavioral activation way, and it relates those to Islamic stories and Islamic values and approaches. So it makes sense for people who will really easily recognize the story about tie your camel and what that means and what the essence of that means, which might be very different to telling somebody, well, you do your part or you be active, because for that might not hold as much meaning for them. So it really unlocks the meaning behind activity, and that's what the training and the approach does. So we undertook a randomized control trial, 142 participants. We had therapists within our talking therapy service and within our voluntary and community sector organisations. So we had 3 organisations that we worked with in the first tranche of this, and we compared that to non-trained therapists and other social interventions that the voluntary sector were delivering, and we found that there were statistically significant better outcomes, that we improved retention so first of all, we also improved uptake. We for the first time started to achieve our uptake targets in Bradford, but the retention of people staying once they'd accessed the service was 3 times more, and that they were achieving reliable recovery rates for their goal-based outcomes, and the comparison of that was statistically significant as well. The qualitative element of that was very much about how the religious teachings enabled the therapists to target behaviours, to think about conversation and think about how they brought together people's behaviours and things that they wanted to change with their faith, and using really positive coping mechanisms to do that, and how that interactive was much more meaningful for people. I think there were lots of things around therapist worries as well. Previously, not wanting to sometimes undertake this kind of approach is through their maybe lack of understanding, lack of knowledge, not being not having the time to do that. And this really made that space to not have to be the religious expert, but to understand and learn through the training and working through the workbook with sometimes the person who's accessing therapy as the source of knowledge and as the source of learning, and really activating what their knowledge is and their assets and their skills are in that space, making that space for that discussion to happen, to really be led by them. It really includes that aspect of how do we decolonize some of the knowledge and the way that we approach services, and the way that we deliver services using a framework that is very recognizable for people, and just that element of being important to be flexible and reflexible in terms of how we approach services. And what we've seen, as I said, a real change in the entire service that we have for talking therapies, in the way that the whole service approaches the way that they engage with service users from all different backgrounds, and how they approach conversation and dialogue. And it's led to a lot more collaboration with the voluntary sector, and we've got some real plans coming forward in terms of how we want to widen our VCS reach, but also think about how we work with other faith groups and other community asset approaches, and think about how we build that knowledge and understanding for that. But it's been a great project. It's been a very difficult one, definitely to mobilise through COVID. There's probably been times from each side where they've well, all parties have wanted to bring it to an end, but persevered through this, and some, as I said, some great outcomes for people, outcome for the therapist, for the service as a whole, and for what we're actually achieving sometimes to sustain the service. So those reduced appointments, not having those missed appointments, increasing appointment use, that efficiency as well that we've built into the system is really important. And I'll stop there because then we've got some time for questions.
Thank you very much, Sasha. So put your hands up now if you've got some questions. We'll just field, I think there's a few in the chat as well. The first one, Sasha, I think you touched on it at the end actually, was about whether you think this approach could be used for other faith groups. So not necessarily the exact language, but how adaptable the approach is.
Absolutely. So we're already starting a piece of work with the Hindu Cultural Society in Bradford to look at adaptations to that. And I suppose you want to adapt it to elements where people are using a faith or a culture, because there are other elements where culture is the way that people approach life and they approach their world around them. And it's that, I think what this has taught us is that element of how do you ask those questions at the beginning, so you understand somebody's framework and the framework that they're living and working in, so that you can then work from that, and the importance of doing that. And I think that comes quite strongly in the proactive care team's approach as well. You work from that person's needs and from what that person's approach is to life.
Yeah, and then there was another question as well, Sasha, from Selena, which was about, I don't know whether the data is available for this, but the dropout was obviously lower, and the numbers of appointments that were attended was higher, but were there actually more referrals? Was there an increase in referrals from the sort of target community, if you like?
So relatively, probably not, but there was probably better engagement about what the service was and what the service does, and that came through the partnership with the voluntary community sector. So there was probably greater engagement, that people who then were accessing the service, and the service is accessed by self-referral. They were much more clear as to why they were accessing that service and what that service would offer them. So that absolutely probably helped with it. And then I think that element of once they've accessed the service, because even previously we were seeing people, we would do big drives to increase access, and then the drop-off rate was huge because they wouldn't return to services. What we didn't see that drop-off happen this time round, and that was primarily because and the feedback is that this was something that was meaningful for them, and they could see how they could apply that not just to the problem that they were coming with, but generally in life as well.
Okay, thanks very much. We've got Mohammed, you've got your hands up, I think. Do you want to come in and ask a question?
Thank you. Yes. Sorry, I put it down again. I was going to put it on the chat, but thank you, Duncan, for giving me the opportunity. First of all, I just wanted to congratulate Sasha on the fantastic work there. That's something really positive and really engaging work. I just wanted to ask the question around recognition of mental health issues, because that seems to be a big issue within the Asian community, as far as not actually accepting that there is an issue around mental health and that can be actually helped with and worked through. There seems to be a lot of denial. You're either physically ill or you're not ill, you're well. And mental health, the fact that we need help and support with that, doesn't seem to register on a lot of people's radar, and it gets dismissed. So just wondering how you countered that.
I don't think we set out to counter that, because that wasn't probably in the remit, but it's a really important aspect for us to be thinking about how through our engagement work, how people frame the issues that they're going through in their life, and the stigma that exists in communities around mental health and mental illness particularly. We often talk about how we've done a lot of work around mental health and people really recognise positive things about mental health, but the stigmas around mental illness are still very much there, if anything, probably increased. So I think that's probably, that comes into the work that we're doing with the voluntary and community sector and with the faith sector itself, as to how do we start to have those conversations. This project was very much about, once people know that they need some help and they're in that space to have help, that we've then got something culturally appropriate for them to access.
Okay, thanks, Sasha. And sort of following on for me as well, because we often have these very sort of flat offers with the NHS, in our sort of screening and IAPT and other services and so on. So presumably, I think what you seem to have shown here is that you can adapt a national programme locally with a lot of hard work, and so presumably there's possibilities that we can do that with, because some of our most stark inequalities are in the same areas around vaccine uptake and screening and so on. So is it adaptable as well, do you think?
I think absolutely it's taking that learning of understanding that there are a large number of our population do live their life through a different framework, and so when we're trying to communicate or share our messages, we've got to really think about how that lands in their framework, because it probably doesn't 9 times out of 10, and so we do need to think about that. And the Muslim population in Bradford is a sizable one. It's about 46%, so it's a sizable population in Bradford for us to think about how we are adapting our service, and it's not completely changing. It's not creating whole new segregated services. This is about how we adapt our approaches, and that's a cost-effective way of delivering our services to our whole population.
Okay, thanks, Sasha. I'm just going to go back to another previous question now. Selena's put another question in about whether people can access this service outside Bradford, which unfortunately is no at the moment, because it was very much within City CCG. But Sasha is very busy spreading the word across the country and in all sorts of different forums. So hopefully we'll see it in other areas soon. Just before we wrap up, I just want to go back to for Sue and Amanda, because of some other really interesting questions. The first one was from Carlton, which I thought was interesting, which was about, do you think that the PAC service maximised impact on care, or it was more of a preventive service, or a little bit of both?
Yeah, probably both, but probably more preventative, because we targeted patients who were just tipping into some frailty or a newly diagnosed dementia or a newly diagnosed long-term condition, and it was about that coordination of not waiting till we hit crisis, so preventing those interventions early. So it was probably much more, and around the self-management, giving a patient the tools to help themselves and look after themselves and reduce polypharmacy, and taking ownership really, and empowering patients. So probably a little bit of both, because our scope is palliative patients, identified in those patients that would we be surprised if they were in the last year of life. So that was probably a little bit more care. But then the other end of the spectrum is those patients with something, like I say, a new diagnosis, and our Admiral nurses, a new diagnosis of dementia.
Okay, thanks very much for that. And then just really quickly, there was a couple of questions around this. Are there any plans to expand?
We've got loads of plans
to expand. The $1 million question. Yeah.
Yeah, we've got plans to take over the universe, but I think I'll let Stu feed in as to where we are with that.
I think we are waiting for a decision. So we were extended. We expected a decision about PACT in City, but it's a model that we believe there's other areas of Bradford with inequalities. We'd love a team in Keighley, similar areas, similar cohort, similar population, but budgets aren't exactly what we would have wanted probably this time last year, so we're just waiting to hear. But yeah, it's a model as well as reducing inequalities, isn't it? It's a proactive way, an anticipatory way of working.
And I think it is about adapting your existing services to work in this much more collaborative way. For me, it's just about shifting people around, and it'll be a brave decision in order to do that. But I think we've got all of the disciplines are already employed, in all the services. All we have to do is remove the barriers and co-locate.
Yeah, I think that's a really good message to end on as well. When times are hard, you've got to adapt and improve what you've already got. So we've had 2 really good examples of that today. Okay, so we'll finish up there. Just to let everybody know, Sophie's just put the link in the chat. There's 3 more sessions this week that you can still sign up for. No, or is it 2? I can't remember. Anyway, have a look on, you'll find out. There is 3. There's integrating VCS support into services. It's 3 o'clock tomorrow. If you've got a spare hour, that'll be an interesting one. And then we've got 2 more sessions, one on community engagement and how communities have really been involved in 2 quite different subjects, but one around physical activity, getting Bradford District moving, and one around genetic awareness and literacy. So that's the community engagement one. And then the last one that we've got is with our Bradford Inequalities Research Unit from the Born in Bradford study. They're talking about leading with evidence and how you actually evaluate this to show impact. So tell your friends about those, sign up, and then hopefully we'll see you all there. So that's all from me. So just want to say a massive thank you to Sue, Amanda and Sasha. Absolutely brilliant presentations, and we'll share all the slides. So everybody's going to get a copy of those, and hopefully see you all at the other sessions. So thanks very much, and bye.
Thank you. Thank you.